Thank Dr. Hamid and Dr. Pirro for putting this together. Our name at Melanoma, of course, and thank you guys for spending this Saturday morning. It's strange, I've been in LA a lot, and this is the first time I've seen it cloudy like this. So usually I'm here like, you know, thank you for spending the beautiful Saturday morning with us. This is still beautiful, but not as beautiful as it usually is. But yeah, so what I'm going to be talking about today is targeted therapy. And some of you I've recognized from prior symposium, you probably remember kind of looking at the old agendas. And you know, when I first did this a few years ago, it was all targeted therapy talks and then one immunotherapy talk. And as you look at the agenda now, it's completely backwards. You know, we've got one targeted therapy talk and a bunch of immunotherapy talks, and that just is reflective of how fast this field is changing and how much progress there has been. You know, truly, I think the future of cancer therapy for melanoma and for a lot of cancers is going to be immunotherapy, and that's going to be the focus of, I think, probably the next decade, if not, you know, more of what we're doing. But targeted therapy is still important. So I'm going to talk a little bit about this, talk a little bit about where we've been and kind of where we're going, and how we're going to integrate this with you know, the care of patients with melanoma and other cancers as well. So I'm from New York. I've been in New York for a decade, and so I've become very accustomed to subway maps. And so when you think about these various kind of pathways in cancer that we're trying to target, this makes it understandable for me. You know, and when you look at how cancer grows or how it's activated, you know, you have to get a signal from outside the cell. It has to land on something on the surface and then turn on these pathways, these various nodes. And it's kind of like getting on the subway car, going down different stations, and finally getting to your end. And when you get to your destination, something happens. And in the cancer cell, that something is the cancer cell grows or it divides. And so, you know, a lot of these subway lines in cancer are broken. They don't have brakes, they're always going. And so that's the problem. Early in 2000, it was found that about half of melanomas have a broken BRAF protein. And that BRAF protein is part of this blue line, which in New York, this would be the A train. But basically, the A train here is broken, it's always going, and it's always telling the cancer cell to grow. And so when that was found, that really started the explosion of trying to develop targeted therapies for this disease, because we know what was broken, and then we were able to try to figure out how can we stop that. Stepping back a bit, you know, we know that this BRAF protein is broken, not just in melanoma, but in a lot of other cancers as well. And some of that's listed here, something called hairy cell leukemia. It's broken in almost all cases, thyroid cancer, less commonly in colorectal and lung cancer. And in the majority of these cancers, the BRAF is a so-called V600E BRAF mutation. That's the mutation we most commonly find in this disease. And we know that if tumors have that BRAF mutation, if we shut the pathway off with these drugs that turn off BRAF or turn off MEK, we can kill the cancer cell. And so this is just a little bit of a diagram. It's a little bit of cell biology of what this A-train MAP kinase pathway is. And you can imagine there's a cell membrane there, and this is a receptor, which, you know, basically is like the antenna on the cancer cell. Normally, if something lands on that receptor, it turns on this pathway that involves this thing called NRAS, these things called RAF, MEK, and then ERK, and then that tells us cancer cell to grow. But if you have a BRAF mutation, you kind of bypass this regulation. So the cell no longer needs that thing to land on the antenna. This is no longer important. This is always turned on, and that pathway is always turned on. And so if we take a drug like vemurafenib, which turns this off, we can kill the cancer cell. You know, and just how well does that work? These are old slides now. You've probably seen them, but I think it's worth bringing up again. These are a series of patients who were treated on the phase 1 trial of vemurafenib. And we did PET scans in patients before they started taking the pill, and then 2 weeks afterwards. And with these PET scans, basically things that are very dark here, for the most part, are going to be cancer. The brain is supposed to be dark because that means it's using a lot of energy, so that's normal. But you can see after 2 weeks of drug, all of this dark stuff in the liver basically normalized. And you can see the same thing here, all these dark spots in the bone, you know, significant improvement, and so forth and so forth. So, you know, this is just after 2 weeks of drugs. You completely shut down the metabolism of the cancer with this pill. And that was really remarkable. We've never really seen that before. This is something called a waterfall plot from the phase 3 trial, where patients were randomized to either vemurafenib or chemotherapy if their tumor had that BRAF mutation. And the way you read these is that here, each bar represents a patient, and if the cancer grows, the bar goes up. You want all the bars to go down. And this is the waterfall plot for chemotherapy. And you can see that the majority of the patients had tumor growth despite the chemotherapy. But look what happens if you do the vemurafenib. It's a completely different picture. You know, almost all patients had tumor shrinkage. It's just this small proportion of patients for whom the drug didn't do anything. And if we use official criteria for how well the drug works, called this response rate, just how much did it shrink, for chemotherapy it's about 5%, and for vemurafenib it's closer to 50%. So that's the power of targeted therapy. You know, and because of that trial, and trials looking at different targeted therapies targeting BRAF or MEK, we had this explosion of new drugs. You know, and you can look, Dr. Pirro was talking about the early drug development for melanoma and how kind of sparse it was. And look what we've had since 2011 in terms of immunotherapy. Oh, you know, I have to update this, sorry about that. We have ipilimumab, pembrolizumab, and nivolumab. But for targeted therapies, we have vemurafenib, dabrafenib, and trametinib now. You know, and all of that, at least the targeted therapy thing, comes from that initial observation in the early 2000s that BRAF is important in this disease. The problem with BRAF inhibition, which some of you may know personally, is that although it can work in most people for a while, it doesn't work forever. And if we look at about how long it works, it's 5 or 6 months. And so we can see that the tumor will shrink. In some cases, it will almost completely go away. And then 5 or 6 months later, it comes back. You know, so that's a problem. So the next question for us is, how do we overcome that resistance? What happened to the cancer to make it not be sensitive anymore? And this is a really complicated slide. But this just goes into some of the ways you know, scientists and we have found that the cell becomes resistant. And the point of this is that the mechanisms of resistance are very heterogeneous. There are a lot of different ways a melanoma cell can become resistant to these BRAF inhibitors. But one of the common themes is that all of these mechanisms lead to activation of that A line, that MAP kinase pathway, despite the fact that BRAF is still shut off. Okay, so that was a little bit complicated. So basically what that means is, although we have vemurafenib shutting this off, other things turn on the rest of this pathway. And so another idea was to see, well, you know, if this part of the pathway is turned on, why don't we just shut it off here? And so that's what we try to do with trametinib. And trametinib is a pill that turns off MEK, just like vemurafenib turns off that mutant BRAF. And so what did we see with trametinib? Well, we saw that it did help. And these are these progression-free survival curves. You know, here basically what you want is, this is time, and this is the number of patients who are doing well. And you want everyone to be like that. So the closer you are to that line up there, the better the treatment. And the trametinib is this. The chemotherapy is this. So trametinib here is better than chemotherapy. But you can see that the line continues to go down. So trametinib worked, but it was not the answer. So the next kind of step that made sense was to try to do combination therapy. You know, if one drug works well and the other drug kind of works well, what happens if you put it together? What happens if we shut off this pathway at 2 different levels? And you know, more recently we've had a couple of drugs that hit both of these nodes, and you've heard about these drugs, I think. In addition to vemurafenib, we have dabrafenib that turns off that BRAF protein. In addition to trametinib, we have cobimetinib, as well as other drugs that block that MEK protein. And so there was a series of trials now comparing the combination of one of these drugs with one of these drugs versus BRAF inhibition alone. And these are the 3 trials. One was something called the COMBI-D trial, which looked at dabrafenib and trametinib versus dabrafenib alone. One was a COMBI-V trial, which looked at dabrafenib and trametinib versus vemurafenib alone. And then the COBRIM trial looked at vemurafenib and cobi versus vem alone. And so what I've highlighted here is the combination. And in every instance, the combination was better than the single drug. Okay? And that's why right now, for BRAF mutant melanoma, if we're going to treat with these pills, it's going to be with combination therapy. And that's why that's the standard of care. It's better. Okay? It's not good enough, but it's better. And so, we're seeing better response rates. We're seeing patients do better for longer periods of time. Some of the patients, we're able to get rid of the cancer altogether, but it doesn't get rid of it in all patients at all times. And so, we're looking at next steps. And so some of the next steps are looking at other nodes in this pathway. And so there are pills now that are being developed that turn off the pathway at this level. And as you can imagine, after we look at shutting this level off, we're going to be looking at various combinations. And so this is just kind of a picture of some of the drugs that we have that hit this MAP kinase pathway. And so that's kind of where we are in terms of targeting the MAP kinase pathway for melanoma therapy. So, why is this not enough? We know that the MAP kinase pathway is important for almost all melanomas, but shutting it off is not enough. And part of that is because of, again, just the heterogeneity of this disease altogether. This is some data from something called the Cancer Genome Atlas Project, where we're taking samples from hundreds of patients with all sorts of different cancers and doing very deep molecular profiling to see what's broken or what's different or what's abnormal in those cancers. And if you look here, if you look at skin melanoma, we see that about half the cases have BRAF mutations. But not all of the BRAF mutant cases are the same. Some of the BRAF mutant melanomas also have CDKN2A mutations. Some of them also have concurrent NRAS mutations. Some of them have had concurrent problems in PTEN. And all these things, you don't have to know what they are. But it's just to say that a BRAF mutant melanoma is different from a different BRAF mutant melanoma is different from a different BRAF mutant melanoma. So BRAF mutant melanoma is not all the same. And so I think if we're really going to use targeted therapy to cure cancer, we have to take this into account. It's not going to be just targeting that pathway for all patients. Another thing that we can do is look at the melanomas that don't have the BRAF mutations. What drives those? And a lot of work's been looking at melanomas with NRAS mutations, which make up another 20 to 25% of cases. And those are different from the BRAF mutations. You can see that they, in most cases, do not overlap. Some of them will have mutations in something called KIT, and some of them will have mutations in something called GNAQ and GNA11. And so over the past 5 to 7 years, there's been a lot of work trying to develop targeted therapies for those diseases. Yeah. So this is very confusing. This is hard to kind of picture. But something that I like to point out is that all melanomas are not the same. And even if we look at skin melanoma, the majority of melanomas arise from what we call skin without chronic sun damage. These are melanomas that occur on the chest or the back or the legs. Melanoma is clearly related to prior UV radiation, and yet most melanomas occur in parts of the body that are usually clothed, that are not exposed to UV. So it's a little bit strange, but that is the majority of skin melanomas. But less commonly, we'll have melanomas arise on heavily sun-damaged parts of the body. For those of you, well, none of you are avid golfers who go out there without hats and sunscreen, I'm sure. You know better than that. But certainly we do see people who spend a lot of time outdoors, who have a lot of sun damage, and these melanomas are uncommon, but these are molecularly different than these. Acral melanomas, these are the melanomas that occur on the palms of the hands, soles of the feet, or under the fingernails. Uncommon, but also molecularly different. And then we have melanomas that arise in the eye, and this is just a scan of the head, and this is a normal eye, and this is a melanoma eye. We can have melanomas arising from the mucosal surfaces of the body, which include the mouth, or the sinuses, or the anorectal area, or the vulvovaginal area. Uncommon and different. And then melanomas arising in the conjunctiva, which is just the mucous membranes of the eye. And so, kind of like in that prior slide where I showed all that molecular stuff, they're all different. It corresponds to this. I mean, just looking at this, it's clear that melanomas are a family of diseases, not just one disease. And if we try to correlate the different clinical subtypes of melanoma with the mutation patterns, we can see that the most common melanoma arising from skin without chronic sun damage is the one that's going to have the BRAF mutations. These other melanomas, the sun-damaged melanomas, or the mucosal melanomas, or the acral melanomas, these more commonly have changes in something called KIT, and then the ocular melanomas most commonly have mutations in this thing called GNAQ and GNA11. So this gave us another kind of target to go after in terms of treating some of these uncommon subtypes of melanoma. And so a lot of the work that has been done in looking at targeting with KIT have used drugs like Imatinib or Nilotinib. These are pills kind of like vemurafenib, but instead of shutting off BRAF, they shut off KIT. And we found that we can get really dramatic results with KIT inhibition in patients who have a tumor with a KIT mutation. And so this is a patient of mine who I treated years ago who had melanoma in the vagina. It was very uncomfortable. As you can imagine, there was a lot of bleeding, a ton of pain. And so we sequenced her tumor, and she did have a mutation in KIT. And so when we started, this here is her tumor there, and on the PET scan, this white stuff is the tumor. And so we started her on Gleevec or Imatinib, which is just that pill that shuts off KIT. And within days, the pain went away, the bleeding stopped. And you can see that in 6 weeks, this mass turned into this. And by week 18, it was virtually impossible to see. And we saw these sorts of results in other cases as well. This is another patient who had an acral melanoma, which is a melanoma on the foot, with all of these spots up and down the leg. And this is a scan at baseline. After 6 weeks of drug, you can see a significant improvement or normalization. And by week 12, this was basically a normal leg, and we did biopsies of some pigmented areas that were still residual. And I'm not a pathologist, but our pathologists tell me that these are just pigment debris. There's no cancer cell there left. And so in this patient, we were able to get rid of the melanoma altogether with this pill. And so based on these data and other studies that have been done, the NCCN has included the use of Imatinib for c-KIT mutant melanoma. And there have been other studies looking at other drugs showing very similar results. For eye melanoma, another distinct clinical and molecular subtype, we've been working to try to use targeted therapy here as well. And this is a disease, it's pretty uncommon. I'll do talks for doctors, and they won't know that this is actually a thing, that melanoma can occur in the eye. But it is uncommon, and it is clinically and biologically distinct from cutaneous melanoma. This is a melanoma that arises from what's called the choroid. And the choroid is kind of the middle layer of the eye, inside of the sclera, which is the white part, and outside of the retina, which is the kind of inner part. And it can also include the ciliary body and iris. And until 2013, there was no effective systemic therapy for this. And really, the standard of care for these patients was a clinical trial. So in about 2007 and 2008, it was found that the majority of these tumors are driven by mutations in something called GNAQ and GNA11. And I apologize, this is another super complicated thing. But I just wanted to point out that here, this is the cell membrane, this is that antenna, that receptor. And those GNAQ and GNA11 mutations make this thing broken. So this is basically always activated and leads to activation of different pathways, including that MAP kinase pathway that we talked about before, and this other pathway called the PI3 kinase pathway. And so as soon as that was found, we started doing work looking to see what would happen. Ideally, we'd like to shut this off directly, but we don't have drugs to do that. So then we asked what would happen if we shut off one of these key pathways like this one. And so here we used a drug called selumetinib to shut off that MET protein. And this being a rare disease, when we did this trial, we partnered with the National Cancer Institute and another 14 trials across the country, as well as in Canada, to pull this off. So this was a major kind of team effort, which I think has been representative of what we've done in the melanoma field in general. And this is what we saw. This is kind of that waterfall plot again. It's formulated a little bit differently, but basically for chemotherapy, you can see that most of the patients had the tumor grow. Their spot is above that red line there, and only the small proportion of patients had tumor shrinkage. Whereas with selumetinib, which is a targeted therapy pill, we had major shrinkage in about half of patients. So again, this kind of showed that with targeted therapy in the right patient population, we could benefit patients. And so this is a patient of mine who had melanoma coming out of the eye at baseline, and she had some disease in the liver. That's a spot of cancer there. And this is on the PET scan. It's very abnormal. And just after a month of drugs, you can see that this basically almost completely shrunk down. And this improved, and the PET scan was basically normal. And so based on the results of this study, Imatinib actually was granted orphan drug designation by the FDA, and we've just recently completed accrual to an international trial to try to confirm those results. And if that international trial is positive, then we're hopeful that we can get this approved as the first approved drug for ocular melanoma. We're trying to make MEK inhibition better for ocular melanoma, and this is kind of an example. I can use this as an example of how we're trying to make targeted therapy in general better. And one thing that we're actively working on is trying to see if we can give the drug better. For vemurafenib, for a lot of these drugs, if you've taken it, you're taking these pills, you just take them every day. I'm not quite sure why you take them every day. I mean, there's rationale for that, but certainly if vemurafenib was IV, you would not be doing it every day. And so, one of the questions for us is it actually good in terms of fighting the cancer to shut off that pathway continually all the time, or is it better to try to pulse it? And there's some potential benefits to pulsing it in that the tumor may not be able to adapt to that therapy. If we can pulse it, give it very high doses, kill some cancer cells, let the patient recover, and then pulse it again, maybe that'll be better. And so we're looking at that sort of strategy in this disease. And then just like with the BRAF and MEK inhibitors, we're looking to see if we can block pathways at multiple levels. And so here, if this is that MAP kinase pathway, we've got one drug hitting it here. If we can find another good drug to hit it here, maybe that'll result in better efficacy. And a third way that we can potentially do this is block two important pathways to this disease. And so here, again, we've got the MEK inhibitor shutting off the MAP kinase pathway, but we know there are other pathways important in ocular melanoma and skin melanoma and so forth. And what if we shut off the other pathway as well? And so as we start to work to develop new therapies and better treatments, these are some of the things that we're trying to work on. And so, I have to update this a bit, but when you look at melanoma molecularly, a lot of it has a BRAF mutation, a significant proportion has NRAS mutations, a small group are driven by KIT, GNAQ and GNA11, and there's this part of the pie called wild type, which means that we don't know what's truly driving those diseases, and there's been a lot of work figuring this out, breaking this pie up a little bit more. And so vemurafenib, dabrafenib, trametinib are all approved for this group of melanoma. I didn't talk too much about NRAS mutant melanoma, but there are studies showing that different therapies, different targeted therapies can attack NRAS mutant melanoma. We've done work, this is just one of the studies, but there have been multiple studies now looking at KIT inhibition in KIT mutant melanoma, and then selumetinib in GQ/G11 mutant melanoma. And so, as we break down the rest of that pie, I think we'll be able to try to figure out which of these targeted therapies, these are newer ones, might be worth evaluating. And so the title of my talk was Targeted Therapy, Where Do We Go From Here? And there are a lot of things. So for instance, for BRAF mutant melanoma, we are working to optimize current therapies. And SWOG, which is one of the national cooperative groups, is looking at a trial where they're using dabrafenib and trametinib, the BRAF and the MEK inhibitor, and they're trying to see if we give that intermittently, will outcomes be better? We have the selumetinib trial for ocular melanoma, that's in development. And there are other trials that are looking at not just changing the schedule of the pills, but how do we incorporate this with immunotherapy? Is it better to give immunotherapy first, then targeted therapy, or vice versa? And so these are questions that are going to be worked on over the next few years, and there are trials that are ongoing trying to figure that out. Again, combination therapies are going to be important, and this is by no means a comprehensive list of trials, but there are trials looking in BRAF mutant melanoma, combining things like vemurafenib with pills that block the PI3 kinase pathway. And then again, with the development of the ERK inhibitors, we're going to be looking at, should we be using ERK inhibitors alone or in combinations with the other inhibitors of that MAP kinase pathway. And then, of course, with immunotherapy, we've got to figure out how do we use this? Do we sequence it? Do we give them in combination? What's the best way to do this, both from a safety perspective and, what's the best way to kind of get rid of the cancer altogether? And then lastly, I think we have to remember that there are a lot of other aspects of melanoma biology that we have not been addressing with these treatments. And you've probably seen this slide. It's shown in a lot of talks, but there are a lot of hallmarks of cancer. And these are basically abnormalities within the cell that allows it to become cancer. And so certainly, these growth pathways are part of it. The immune system is part of it. The DNA damage repair pathway is part of it. And each of these is probably a series of lectures by itself. One thing that I was just going to talk about, because Dr. Hamid and I are collaborating on some trials targeting what's so-called angiogenesis, I thought I'd just highlight a couple of those trials for you. But certainly, there's a lot of work targeting all of these different hallmarks of cancer. But one of these hallmarks is so-called angiogenesis. And you can imagine that for a cancer to grow, it has to create its own blood supply. If it doesn't create its own blood supply, it can't live, it can't grow. And so the question is there a way that we can target that process and get rid of melanoma? And this is a slide that Dr. Hamid and I got from Mike Atkins, who's leading one of these trials. But when you look at blood vessel production, one of the key things in the body is this thing called VEGF. And VEGF is just a protein that goes around in the bloodstream. And when it lands on blood vessel cells, it leads to the growth of new blood vessels. And so you can see that if you look at patients with melanoma who are treated with a BRAF inhibitor like vemurafenib, you can see that before treatment, they've got, this is just where they start at for VEGF levels. And then, while they're being treated, the VEGF levels are kind of the same. But when the cancer grows, you can see the VEGF levels shoot up. And so that maybe suggests that maybe this abnormal VEGF pathway or angiogenesis pathway is somehow part of the resistance mechanisms for BRAF inhibition. And so we know that there's been some studies showing that various inhibitors of this pathway have some efficacy. This is just an old trial looking at a drug called bevacizumab. There's been interest in combining BRAF inhibition with drugs like bevacizumab. And so Dr. Atkins, who's now at Georgetown running the program there, developed this trial where he's taking patients with melanoma, and they're being randomized to either vemurafenib and cobimetinib, which works in BRAF mutant melanoma, and half of the patients are going to get bevacizumab, and half the patients are just going to get the targeted pills. And so hopefully, this question, and remember it's randomized, but everyone gets kind of the standard of care BRAF therapy, okay? It's just some of the patients get the bevacizumab, which is the angiogenesis drug, and some don't. But I think this is an important trial, and if we can actually pull this off, this will answer that major question of if targeting angiogenesis is useful in this disease. And this trial is going to be conducted through something called the Melanoma Research Foundation Breakthrough Consortium. And I just point this out just because I want to make it clear to everyone that this is really a collaborative effort. And the MRFBC, it's a group of 18 centers, and the Angeles Clinic is part of it, and Memorial Sloan Kettering is part of it, and Columbia is part of it. And our whole purpose is really to try to accelerate the development of these new treatments. And so that bevacizumab trial is going to be conducted through this mechanism, and it's in the process of being activated at all of our sites now. When you look at the way that cancers make their blood vessels, it's interesting to note that their blood vessels in the cancer are abnormal. They're not like normal blood vessels. In our normal body, the generation of blood vessels is very highly regulated. You have to be sure that you can get the blood supply and the nutrients and the oxygen to your entire body, and it's done in a very structured and organized fashion. But if you look at the tumors, the blood vessels are disrupted. They're not normal. Although they are making new blood vessels, they're twisted, they're contorted, they're abnormal. And because of that, there are areas of many tumors that have these big, what we call hypoxic regions. And so normally, most of our body has enough oxygen, but in the tumors, there are going to be areas or pockets where there's not a lot of oxygen. And it turns out that tumors that live in that hypoxic area are more resistant to chemotherapy, they're more resistant to radiation therapy, they may be more resistant to immunotherapies, and that's because you'll hear a little bit more, I think, about these cells called regulatory T cells. Those are the bad T cells that allow the tumor to grow. There's some data to show that there are more of those bad T cells in those hypoxic regions. And so you can imagine that if we can develop a treatment that specifically targets a hypoxic region that actually will go there where other chemotherapies can't or other treatments can't, then maybe this would be a good thing. This is another study that Dr. Hamid and I are working on, looking at a drug called Evofossamide, or TH302. And this is kind of a fancy chemotherapy. If you look at this part, I don't know if there are any chemists in the room, but this molecule is the chemotherapy part of this drug. But if you look at the way this thing is metabolized, this is the starting drug. In an area of the body where there's a lot of oxygen, this thing is metabolized to kind of the next step, and the drug goes from this step to this step and then to this. In areas where there's normal oxygen levels, it'll turn into this, but it'll turn back. And so it's in this dynamic balance, and you actually never develop the real chemotherapy. But in areas of the body where there's low oxygen content, this full pathway can occur. So this thing will turn into that. So this thing only turns into active chemotherapy in areas of the body that have low oxygen content, and that's exactly what tumors have. And so in one of the prior studies of this drug, there were a series of patients with melanoma treated with this. And so this is a 74-year-old patient with melanoma who had prior chemotherapy with dacarbazine. And this is a while ago. That's why we were talking about chemotherapy. But this patient had chemotherapy and then went on the trial of this TH302 drug. And you can see that after 2 months of therapy, this liver lesion, which was 13 centimeters, shrunk down to this. And this lung mass shrunk down to that. And so we saw multiple patients who had outcomes like that. And so based on that, we're conducting a trial specifically in patients with melanoma, which we know is oftentimes has high areas of hypoxia. And this is not a randomized trial. In this trial, every patient will get the drug. Part of what we're doing is trying to fully understand how these drugs work, how we can best select patients in whom this drug's going to work. And so there are a lot of special studies that we're doing here. We're doing these special PET scans, where instead of measuring glucose uptake, we're measuring hypoxia with these PET scans, because it may be that the patients whose tumors have a lot of hypoxia, maybe they're the ones who need this drug. We're going to be doing biopsies so we can look exactly at the blood vessels and kind of what's going on before treatment and after treatment. And so I think this is another important study that, again, will give us a lot of information and help us better understand how we can target that angiogenesis. And so this study is being done in the US as well as in Canada as well. So I could go on because there's a lot to talk about, but I think we have to switch to immunotherapy. So in conclusion, I do want to say that effective inhibition of the MAP kinase pathway at single and multiple nodes, it's really been a paradigm shifter for melanoma. Melanoma has been a model disease for targeted therapy, and what we've learned in melanoma has been applied to lung cancer and other cancers as well. The standard of care for BRAF mutant melanoma is going to be combination BRAF and MEK inhibition, and then targeted therapies for other molecular subsets, have been developed or are being developed. What I would encourage is, this is a very savvy audience, I know, and so I don't think I have to say this, but I think the clinical trials are really critical. These advances cannot be made by the doctors and the scientists alone. This is a group effort. We need you guys involved, and I think together, we can really make a difference here. So I think I'll leave it at that. Thanks.